Hope you're all doing good. Guys, welcome to the OMR series. I hope this is making your OSCEs real easy. And make sure to watch this series, which can help you to prepare very quick and in a very interactive way. So, and definitely thank you so much for all the love and the support which you guys have given for the first one. So again, this would be the second one based on the labor and delivery module. And today, as per the demand, I am going to do the labor ward prioritization. Yes, to start with the success code. Remember, yesterday is a history, tomorrow would be a mystery, and definitely whatever the time you have got is the present or the gift. So from wherever you are, start preparing and kickstart your day with positive note, and nothing is impossible. So what we are going to do and what is the agenda of today thing? Basically, today it is all about making your labor ward prioritization very easy, helping you to understand how to go about the time management, and definitely to work around for how you can manage so many cases, because before there used to be only 4, 5 or 6 in MRCPI OSCEs, but now they have made almost like 10 cases which are evolving. Not every case, but let's see how would I be able to manage this time and do it like a task. Okay. Yes. So yes, we shall do as a task. Aisha. Hi, Aisha. Thank you so
Hi.
much for joining. Thank you. So Aisha will be examiner. I'm sure she would love that role. So let's start off with the task. I'm keeping the timer on. Yes. Okay. Fine. I'm Sowmya, one of the candidates for the exam. I've gone through the scenario and I'm happy to start the discussion.
Hi, Sowmya. So this is the labor ward board, and you'll have to prioritize the cases, allocate your colleagues, and manage the labor ward.
Sure, thank you. I'm aware that I'm receiving the handover at 8 o'clock and I'm aware of the staffs given to me. And definitely as the scenarios, I would be allocating the priority, but if the scenarios are evolving, I'd make sure that I would escalate in a similar way. Looking at the labor ward board, I would first want to rush to room number 5 because I can see that this is a obstetric emergency, which is a postpartum hemorrhage. And also I can see there's a postpartum lady with a 3rd-degree perineal tear who is having the bleeding. So I would be rushing with, along with definitely there is a midwife and the GP trainee also I would take along to make sure to understand what's happening. So I would start with communication, resuscitation, arrest of bleeding, and management together. So I would ask the midwife to start with the 2 IV access and collect blood for full bed count, coagulation profile, LFT, RFTs, and group 1 cross match. And also there will be a scribbler who will be writing down all the events. And definitely we need to start with the oxygen, and depending upon her observations, there should be a continuous INO start to be put, and we will be quantified blood loss to be done. And I would quickly have an examination of the uterus and if there is any tears, associated tears as well. And also I would ask them to put the catheter quick. And definitely if it is an atonic PPH, we would start off the protocol with the depending upon what drugs been given, whether the oxytocin is given. And also before that, I need to make sure that the placenta is delivered, and a quick history of drug allergy and the 3rd stage of labor and about the baby. And I would start with oxytocin, and if methyl ergometrin based on contraindications, and the carboprost and 15-methyl PGF2 alpha and things like that. So I would definitely want to know if there is any cause which we already have got here.
So the observations is BP is 100/60, pulse is 96 per minute, and uterus is well contracted.
Okay, thank you. So this is a case of actually then traumatic PPH. So when we are doing all this resuscitation, definitely my consultant would be alerted, and the anesthetist also would be alerted, and we would be shifting back quickly them to the theater. But under with the consultant's supervision, or with the consultant, we would be exploring and making sure that the traumatic PPH is controlled. And I mean, we have to suture, and blood transfusion would be started as well based on the requirements, and also third-degree perineal tear would be sutured. And the postpartum, there will be incident reporting, laxatives, and debriefing the patient and the team as well. Now, once we have managed the emergencies, I would like to go from room-wise. The room number 1, I can see that this is a postpartum lady who had an unfortunate event of IUFT, and she had a fever at admission. This is what worries me. So I would be sending my GP trainee, because I would be stuck here. So I would be sending my GP trainee to have a look and to rule out sepsis, like whether the sepsis bundle has been started and what was the investigations. And also I would also will be seeing later on to explain to her what exactly happened, and also the need for lactation suppression has to be discussed, and also the debriefing the woman, and also like debrief midwife should be there, and also probably we need to look into her VT risk assessment and discussion of postpartum consent, and most important, looking into the risk factors why this happened. So that's what I would be doing. Do we have any other additional findings for her?
She has no fever now, and all her observations are stable.
Okay, fine. So then that means to say this would be actually right now, this could be a routine case because she is already settled, but definitely the psychological part to be taken care. Coming to the room number 2, I can see a primary gravida who is in active labor with presenting with the leaking. So I would definitely need to know her, the CTG, and also the current, that's the current examination, I would believe, if there is any other associate as additional risk factors.
No risk factors.
No risk factors, and the CTG is fine.
Yeah.
Okay.
CTG is normal.
CTG is normal. So if the CTG is normal, definitely I would be letting her, like with the midwife can take care of this. Midwife is the one who will be looking into that, and I will ask her to escalate if there is any additional findings or if there is anything comes up. Otherwise, we will go with the labor plan as usual. Now, coming to the room number 3, we have a multiparous lady who is in active labor in the water pool, and the liquor is clear and CTG is normal. So here the midwife can take care definitely, and because everything seems to be fine as of now. And if there are any escalations, they would let me know, and definitely the temperature of the water to be maintained, and I'll make sure that the GBS report to be checked before anything. Room number 4, I can see that there is a type 2 diabetes at term who is waiting for the induction. Here, I need to know the couple of details, how is her diabetes controlled, and what's the whether she's on insulin, what is the estimated fetal weight, and the Bishop score, and as well as the fetal heart race.
So the baby weight here is 4.2 kg, and her sugar levels are uncontrolled. It's not controlled, so shifted to insulin.
Okay. So definitely I need to have a detailed discussion for her. So probably I would be finishing all my emergencies and then only I'd be going to her. This would be a routine as of now. So I need to discuss with the woman about her plan of care, and because shoulder dystocia is one thing which I'll be worried about, so I will be discussing with her the pros and cons of normal delivery versus cesarean section, and the risk of PPH, and also maintaining her blood glucose levels. We need to maintain the blood glucose levels between 4 to 7. So that is something which I need to take care, but I would definitely be this a routine. I would be looking into her once all the emergencies are done. Room number 5, we have done. Room number 6, here I have a post-dated primary gravida who is on epidural, and CTG is normal, and she's been fully dilated since 3 hours. So definitely here the midwife, anyways, there is one-on-one care, but I would want to know from the examination findings, what is the station and what is happening here. Yeah. Like what is the examination
Station
finding?
is +2, and it is left occipital anterior.
Okay. So here I would definitely be thinking of doing an instrumental delivery because 3 hours done and it is left occipital anterior and it is +2. So we would need to discuss with I would discuss with the woman about the pros and cons of instrumental delivery versus the normal delivery. I need to alert the consultant. Consultant by then, like if he is busy, I can always call the second on call if to be around, and the neonatologist to be informed, and definitely if there is like after the delivery, we need to collect the paid cord blood gas samples and so on. Coming to room number 7, this is a preterm diamniotic dichorionic, but it is cephalic to transverse. She's in labor, and I can see that she's 3 to 4 centimeters dilated. So here, Again, I need to make sure that the NICU beds are available. I need to make sure that the neonatologist is available and they are aware of this case, and consultant need to be informed. And I need to look into the labor plan as well, because the second baby is transfers, and IV access, group and safe, epidural analgesia we can discuss with the woman. Definitely the first one is a cephalic, so it would go as decided. This could be a semi-urgent case as of now because it's a twins and it has to be seen by a doctor. So I would ask the GP trainee to have a look, but I would definitely go back and have a look into her. And after the delivery of the first twin, we can look into the presentation. If it still transfers, we can shift it to the theater and think of probably doing an ECV. And then internal podalic version, like if ECV fails, internal podalic version and assisted breech extraction. Now, coming to room number 8, a preterm PPROM with a breech. Again, she's latent phase of labor, so I need to make sure that a doctor should be seeing this. So definitely the GP trainee would have a first look and then I would go and talk to her. I have to alert my consultant and the neonatologist as well and need to discuss about the pros and cons of normal delivery versus cesarean because she's a 29-weeker. So all these, room number 7 and 8 preterm labors, we need to always think of GPS prophylaxis wherever required. And if and also PPROM for room number 8, CBC CRP to be set. Room number 9, class 3 obesity who has delivered 4 hours before. Is she has an epidural or so that are any other risk factors? What is the bleeding and things like that? Okay. Room number 9.
She's not on epidural. She's not on epidural.
Okay, so then I would definitely start up the VT, low molecular weight apparent prophylaxis and early mobilization and lactation support, as well as I need to also support her, the perinatal mental health, because they might be at more risk of depression and blues. The last room, she is a 34-weeker who is coming with reduced fetal movements. This would be an emergency one. Room number 9 is routine as of now. My midwife can take her. And room number 10 is again semi-urgent because she's coming with reduced fetal movements. Midwife and the GP trainee can have a look and check with the Dopplers. If the fetal heart sound is absent, then it becomes, we have to escalate as emergency and we might have to be arranging an ultrasound. So yeah, this is the prioritization of all the rooms. Exactly done, I think, on time. Okay, fine. Okay, so yes, Aisha, how was it?
Yeah, your prioritization was right. You took most of the time for the emergency cases, which is rightly done. You have to go in detail about that because that's a most urgent cases, and then give each you have to touch the most important points in other rooms, which you have done. Again, allocation you have done, but again, little bit more precise. Okay, I would send this to this room would have been much better. Rest, you have allocated all the your colleagues to all the rooms. Again, little more, be specific. That would add much to the station.
Yeah.
Then I think most of the things have been covered. You have touched the most important part in each of the rooms. Yeah.
Yes. Yes, Aisha, thank you. So, like, see, as I started off, I think this one would take time. So, my reflection of the task was PPH was really taking the time. And I know that I have 10 rooms in hand and I have to cover because each room has a time. And I think when I came here, 8 and 9, I combined, I knew that I would not be 7 and 8, I combined because I knew that I cannot go back. Okay. So, I think from the examiner point of view, also, it is very easy. Like if you know that there is a less time, combine everything and put it together. Not that you will tell 7, 8, 9, 10, but at least 2 rooms, as I mentioned about the GPS prophylaxis. And yes, there could be evolving scenarios for everything. So the main point with all the cases is, so like here, I think Aisha mentioned it was normal. So it could be other cases, there could be, let's do room wise. No fever, sepsis, look for the factors, debriefing and postpartum consent, whatever. Here, if the room number 2 mentioned that there was variable, for example, Aisha mentioned to me CTG was normal. If it was not, if it was pathological, always discuss about conservative measures, scalp stimulation, FBS, you know, it is not done, FBS versus cesarean section. Room number 3, nothing to be done, continue the normal process. And I wanted to add on temperature should be maintained. You can avoid that actually if you do not have time. Room number 4, yes, very, very important, shoulder dystocia, blood sugar maintenance. Rest of the things, you will be able to talk. Room number 5, yes, you need to make sure that, like, ideally, they do not expect you to tell the dose, frequency, then it would take 5 minutes. So you need to be quicker and do not go ahead till the hysterectomy and ask what is the cause. So if you give a medical protocol and then ask. Room number 6, instrumental delivery. As an ST3, you can do, but it's always good to have a consultant. That's the reason I was trying to tell, like, it's a good idea if second and on call could be there. Room number 3, definitely twins to be seen by a doctor. So I can push my, there is already midwife. I can push my GP trainee there, and I can always go back and have and alert the people required. And again, room number 8, GP has to be seen because we don't know diagnosed breech, undiagnosed breech, what is happening, and whether the CTG is fine, whether the baby's heartbeat is good. So a doctor has to see, followed by which you would be seeing. Room number 9, very important, VT prophylaxis you can start as soon as possible. And definitely you need to talk about the breastfeeding and all those things. And room number 10, for sure, depending upon the cause. So it is like a marathon. If 10 cases, see, if it is 6 cases, you will be super duper, you will be able to finish. Once it crosses 8 cases, it's always a challenge how you're going to finish. And here the additional stress in MRCP, what you've got is you don't have time, reading time. Okay, so 1 minute would automatically go for the paper to read, and you have got roughly around 9 minutes. And if it is not evolving, you can 100% finish. But if it is evolving, then there is a challenge again. So try working around. I wouldn't say I did my best. I had my share of things, because if I don't keep the timer, I can go on forever. But I knew that I had to finish in time. So a couple of important things. Always interviews, like what we did. Okay. You cannot say that, okay, I'm seeing this, I want to do that, I want to do this. No, first introduce. Let the examiner speak. I know that Aisha is eating up my time, but I have no option other than to let her talk, right? And always see the board. Urgent room, talk about that. If there is no urgent room, you can go room wise. Summarize case to the examiner. If you had observed, I just told postpartum, PPH. I never mentioned bleeding 800 ml because the examiner doesn't want you to read the thing. Each case, it's a good idea to tell who, when, what. But if you cannot follow that before you leave that room, tell at least what is the urgency and what you would be doing. Keep it crisp as much as possible. Manage time. Always highlight the important points. For example, IEFT, sepsis. Okay, so buzzwords. Always try to bring in the buzzword. Always try to bring in people around who can help you. For example, scribbler in PPH is very important. Obviously, I didn't have time to talk about the incident reporting and all. We don't know, because it's more than 1,500 ml is what incident reporting you would be doing. Definitely, if this was 5 cases, I would have explained, I need to debrief the team, I need to debrief the women, but there is no time. So you have to move on. And whenever you're confused, always think, what would you do if you are put 10 cases and you are the leader of the board? So that's all is required. Guys, there is no black and white rule for the labor ward board. You can do in any way. You can do room wise, you can do urgent, semi-urgent, whatever, but make sure that it is done and covered all the rooms, because each room has a point to, like, you have a marks to get. Hopefully this would have given you an insight. Yes, Aisha, if you have any additional inputs or any additional things.
I think you have covered most of the points, Sowmya. I don't have much to say. What I want to say is that touch and go, touch and go, touch and go. This is what I want to say. Just mention it, go, mention it, go. Do not elaborate it, because if you start elaborating it, you'll have no time to complete the station.
This exactly, that's the point. So, yeah. The crisp buzzwords, but you cannot also tell the words. You have to make sentence. Try to use the shorter sentences. We are all in the learning process. Even now, like, even if you have, see, if the same thing in part 3, you get 15 cases. There we cut short. So it's all about, like the time given, we try to fix in that. Practice, guys. That's the only way around, to practice more, and to, like repeatedly doing these things would be helpful. And probably these things are giving an insight, because we are all humans. We are all bound to do the errors. But if you don't miss the most important things, the points would be getting to. Okay. Thank you, guys. Thank you so much for actually subscribing the channel and watching and for sharing. Thank you, Aisha. Thank you so much. Thank you, guys. Thank you.